I'm happy to do it with you again today. I'm going to start with two administrative slides, really. The first is to let you know that this is part of the webinar series of the International Bipolar Foundation. On this slide, you can see information about the foundation and a way to donate to help support some of their activities. And then on the next slide, I'm going to give you my disclosures, which is I've done research consulting and received honoraria from Sanofi on pharmaceuticals. As mentioned, I'm also the editor of the Psychiatry Letter, which is a monthly newsletter. And here you can see the website for the Psychiatry Letter. If you want to look on the website where there's a lot of free material around some of the issues that we're going to be talking about and links to articles, it's a good resource. And also there's a subscription newsletter which you can access through the website as well. If you're interested in some of the ideas that I'll be presenting and want further information or want to follow the discussions that I have with other colleagues about these clinical topics, the newsletter could be a good resource for you. Okay, so we're going to start with a discussion of the beginning aspects of talking about antidepressants and bipolar depression, which is what kind of studies exist that show whether they work or not. And what I'm presenting to you here is a meta-analysis from a few years ago that we've actually recently updated, finding the same results, which is that antidepressants are not looking effective for bipolar depression. If you're familiar with meta-analysis, I'm not sure if you can actually see my arrow, but in the middle of the meta-analysis there's this line, and each one of these little boxes are the effects of the antidepressant over placebo. And then the horizontal lines are confidence intervals, which means how much confidence do we have in the results. If they're small studies, you have wider confidence intervals, which means the results may vary in reality. And if the confidence intervals cross the vertical line, that means that there's really not any meaningful effect. And as you can see, most of the studies cross the vertical line, which means most studies find little, if any, benefit with antidepressants over placebo. The little diamonds on the bottom are the summary numbers, which suggest, you know, a very small benefit, if any, but it touches the vertical line, which is no benefit at all, no difference from placebo or sugar pill. So overall, there are actually 4 or 5 studies in this meta-analysis. There are more studies in another one that we recently published. But overall, there's half a dozen or more studies, and they don't find benefit with antidepressants in bipolar depression. They're equivalent to placebo. On the bottom, it says affective switch, and that reflects whether the antidepressant causes a manic episode. And again, overall, there's no difference between antidepressant and placebo, which some people have interpreted to mean that the drugs don't cause mania. But you have to keep in mind that in these studies, the patients are all on mood stabilizers. We do know, or mostly they're on mood stabilizers. We do know that if people are on mood stabilizers, the risk of getting manic is lowered. That doesn't mean that drugs don't cause mania at all. It just means they cause them less, especially if patients are on mood stabilizers. But the summary interpretation of this is that the drugs don't work, and if you give them with mood stabilizers, they have a low risk of causing mania acutely. A lot of people would say, well, it's okay to give them because they don't hurt you. But when the drugs don't work, you shouldn't be giving them. I've never understood the view that it's okay to give these drugs when the studies repeatedly show that they're ineffective. Let me move forward and we can talk about that issue some more. Now this is to give you an example of the kind of study that looks at antidepressant efficacy in bipolar depression. Here you have a study comparing quetiapine or Seroquel, which is a so-called antipsychotic. I prefer the term dopamine blocker. It is clearly more effective than placebo. And it's been shown to be more effective than placebo, and it has an FDA indication for this reason for bipolar depression. The orange line is Paroxetine Paxil. As you can see, it's basically the same as placebo. There's not a clinically meaningful difference here. It's not statistically different. It didn't work. Now you notice that patients get better, and this is an important aspect of the reason why clinicians continue to use antidepressants so much in bipolar illness. And they seem to have difficulty understanding that the drugs don't work. One reason is if you look at the placebo arm, the patients got better. If you look at the paroxetine arm, the patients got better. There's no difference between placebo and paroxetine, which shows you that the patients are getting better because of natural history or because of the mood stabilizers they're getting in the study, but it's not because of the serotonin reuptake inhibitor, the so-called antidepressant. It's not because of the paroxetine. Well, clinicians in practice don't use placebo. They just give the drugs. So if this was a patient in practice and you gave them paroxetine, you would see that they would improve. And you would conclude that they improved because of the paroxetine. But in fact, they did not improve because of the paroxetine. They improved for other reasons. This is part of the reason why I think it's difficult for people to understand that antidepressants don't work in bipolar depression. What we mean by them not working is not that the patients don't get better. We mean that they get better without the antidepressants. There's no need for the antidepressants. And as I'll show you, there's harm with the antidepressants, and that's another rationale and not to use them as safe. Now, this is a meta-analysis that we published some years ago of maintenance treatment with antidepressants, which means prevention of mood episodes. And on the left-hand side, you have prevention of depressive episodes. On the right-hand side, prevention of mania. Again, the vertical lines, no difference between the groups. You can see a little benefit for prevention of depressive episodes, but not much. You can see some worsening of manic episodes, more so than the preventive benefit. And in the same paper, we analyzed it by, if we limit our analysis to patients who are on mood stabilizers, because in some of these studies they were not on mood stabilizers, then there really was no benefit from adding antidepressants for prevention of depressive episodes. So again, when you look at the randomized placebo-controlled studies, which are our best scientific studies, you do not see evidence of robust benefit with antidepressants for either short-term acute improvement in depression symptoms, as we looked at previously, or in this case, for prevention of depressive episodes long-term. In both cases, the drugs don't seem to have much benefit. And in fact, you see in this maintenance trial that they can cause more manic episodes long-term, which raises the issue of long-term destabilization, which I'll talk to you about in another moment. Here's just another example of one of the studies in these meta-analyses. To give you an example, again, of what these studies look like. This is a classic NIMH-sponsored study called the STEP study. Patients were acutely depressed. They had bipolar illness. They were on mood stabilizers, and then they were randomized to getting either an antidepressant, which was paroxetine, bupropion, Paxil, or Wellbutrin, or neither, placebo. And if you look at the recovery rates, you can see that antidepressants were not better than placebo for acute depression improvement. If you look at manic switch rate, again, there was no difference. Paroxetine and bupropion are two of the so-called antidepressants that are most proven to have a low manic switch rate. So it's not surprising that there wasn't much here. Again, all the patients were also on mood stabilizers, which is protective for short-term manic symptoms. But again, there was no benefit with the antidepressant or placebo. It doesn't make sense to use a medication that's ineffective, even if it doesn't have side effects that you're concerned about. There was an earlier meta-analysis that looked at the issue of antidepressant-induced mania, and in this case, I pulled out the tricyclic antidepressants just to show that in these randomized trials, if you limit yourself to the tricyclics, you do have this diamond in the bottom, which shows a threefold increased risk of getting manic on those antidepressants versus either other medications or placebo. So this just gets to prove the scientific point. Some people sometimes will doubt whether antidepressants cause mania at all. Well, tricyclic antidepressants are antidepressants, and they certainly cause mania. It's proven in these randomized trials, threefold increased risk. The risk may be indeed lower with some agents, some of the serotonin reuptake inhibitors like paroxetine. But the general scientific question, whether any antidepressant causes mania, it has been proven in randomized trials that tricyclic antidepressants do so. Now, in the Stanley Network, which was a bipolar research network some years ago, they did a large randomized trial of different new antidepressants. And here they compared bupropion, sertraline, and venlafaxine. And what they found, if you look specifically in the manic switch bar, is twice as much risk of getting manic acutely in this double-blind randomized trial with the venlafaxine than sertraline or bupropion. And the difference was statistically significant. So again, even though some antidepressants may have lower risks, like bupropion, it doesn't generalize that no antidepressants have acute manic switch risk that's proven in randomized trials. In this case, you can see that venlafaxine is proven to do so. And also, there was some long-term destabilization with venlafaxine. Obviously, venlafaxine has some norepinephrine effects, like the tricyclic antidepressants, and it may be one of the worst agents to use in bipolar depression. Now, in DSM-5, a change has been made in the definition of bipolar illness. It used to be with DSM-4 that if patients had manic episodes with antidepressants, that was an exclusion, that one wouldn't be allowed to avoid the diagnosis of bipolar illness if the manic switch happened with antidepressants. With DSM-5, that exclusion has been taken out, so even if the patient has manic switch, manic episodes, and they're on antidepressants, and you think they're related to the antidepressant, you are still supposed to diagnose bipolar illness. And this is an appropriate change, in my view, based on these kinds of data. As you can see here, the STEP-ED study, which we just reviewed, had a 10% manic switch rate with antidepressants in the bipolar depressed patients. There wasn't a difference between drug and placebo, but I want to just for now emphasize the point that 10% of the patients got manic when they were on the antidepressants. That might have been because of the natural history of the illness, but still, that's how frequently it happened. In the STAR-D study, which was a study of major depressive disorder, so-called MDD, non-bipolar depression, the manic switch occurred in only 2 patients out of 4,000 patients, despite repeated treatments for acute depressive episodes. In other words, 0.05%. The frequency of the manic switch is 200 times more in the bipolar patients than the non-bipolar patients. Whether or not there's a causal relationship, we can at least say that if you see a manic switch with an antidepressant, it's 200 times more likely to be someone with bipolar illness than non-bipolar depression, which is a huge association and is consistent with the perspective that basically manic episodes don't happen, even with antidepressants, unless you have bipolar depression. They don't happen in so-called MDD, or very rarely so. Now, besides acute manic switch, which is a short-term immediate effect, I want to turn to long-term mood destabilization, or long-term worsening of bipolar illness with more and more mood episodes over time. We could call this cycle acceleration, we could call it rapid cycling, but what we're seeing is that 2 months, 6 months, or longer after the antidepressant has started, the patient's having more and more mood episodes. Now, frequently, the mood episodes are not necessarily severe manic episodes, although they can be. They may not even be notable hypomanic episodes, although they frequently are. What the patient frequently notices is that they're having a lot of depressive episodes. And essentially, paradoxically, the antidepressant is causing more depression over time. And it's doing it by causing cycling into and out of depressive episodes, more so than before the antidepressant. Now, there are only a few randomized trials that have tested this matter. More recent ones have been done by our group, and there are some non-randomized studies where people claim otherwise. But the randomized data do support this association. I'll give you an example from one of our studies. We took patients who initially had bipolar depression and responded to a mood stabilizer plus an antidepressant openly. At least they seemed to get better with the combination. We then randomized them to continue the combination or to come off the antidepressant, and we followed them for a year. And what we found was in the rapid cycling patients that they had 3 times more depressive episodes in the 1 year of follow-up than the non-rapid cycling patients if they were in the antidepressant arm. If they were in the non-antidepressant arm, if their antidepressant was stopped, the rapid cyclers did not have more depressive episodes than the non-rapid cyclers. So these are randomized data that support the association of antidepressants worsening rapid cycling illness and causing more and more depressive episodes over time. In clinical practice, what this translates to, in my experience, is that when you have patients who have refractory bipolar illness, or if someone doesn't seem to be getting better despite multiple mood stabilizers and anti-manic drugs and antipsychotics and such, the reason they're not getting better frequently is that the antidepressants are destabilizing their illness, causing more and more mood episodes over time. In other words, the antidepressants are mood destabilizers counteracting the benefits of the mood stabilizers. And the antidepressants need to be stopped to have a fair therapeutic mood stabilizer trial, or to trial medications in general that are effective in bipolar illness and give them the best shot of working. In my view, at least a half of the cases, if not more, of apparent treatment refractory bipolar illness resolve by stopping antidepressants. By the way, for treatment refractory depression, I think the reverse is the case. About half the cases are misdiagnosed bipolar illness. They also resolve by stopping antidepressants and by using mood stabilizers instead. Now, in the last few years, we've been conducting a second large randomized trial to address the question of antidepressant efficacy in bipolar depression. This study has been presented at an American Psychiatric Association meeting and is currently submitted to journals as in review. What we did is we took Citalopram, a serotonin reuptake inhibitor, and we compared it to placebo, both short-term and long-term, 6 weeks and 1 year, for bipolar depression. All the patients were on standard mood stabilizers. They got randomized to citalopram being added or placebo. In the acute phase, the first 6 weeks, the black line is placebo, meaning mood stabilizer alone. You can see the patients get better. The red line is citalopram, mood stabilizer, plus citalopram. You can see the patients generally get better, and there's no difference between the two arms. Again, in clinical practice, you give the antidepressant, you think patients are getting better. In fact, they're not getting better because of the antidepressant. They're getting better because of the mood stabilizer or because of the natural history of the illness. Let me emphasize that the natural history of the illness is important because the nature of bipolar illness is that the mood episodes go away by themselves. Depressive episodes last 1 month, 2 months, 3 months. So if you follow people for 2 months or so, 3 months, many of them get better. You don't need to use an antidepressant. In fact, if you gave them nothing, they would get better. But we give them the mood stabilizer more for the some short-term benefit, but also for long-term prevention. And that's the more important point. As you can see here in the maintenance phase, citalopram versus placebo, again, there was no benefit with the antidepressant long-term over placebo when you follow them into the maintenance phase, which is 6 to 12 months of treatment. The mood stabilizer leads to benefit. The patients improve, but the antidepressant adds nothing. By the way, this is the first and only placebo-controlled study of any serotonin reuptake inhibitor in bipolar illness for the maintenance treatment. And we just did this study over the last 5 years. These drugs have been around for over 20 years, but no one had ever done a study long-term in maintenance treatment showing that they're more effective than placebo. No one had ever even tried. And yet they're the most commonly used class of medication in bipolar illness, and they're used long-term by most people with zero scientific evidence to support such use. We now have provided this scientific evidence, the first such study, and it proves they don't work, which again, if we are going to practice evidence-based medicine, we should stop using these drugs. Now, I would like to point out that some people view that type 2 bipolar illness may be different than type 1. In the previous studies I showed you, including the study I just showed you, we included both type 1 and type 2 bipolar patients, and we found no differences between type 1 and type 2 bipolar patients in terms of antidepressant efficacy. The drugs were ineffective in both cases. Some people think that at least the drugs are safer in type 2 bipolar depression. And that's true. They seem to have a lower manic switch rate in type 2 bipolar depression than type 1, but it's still not zero. So in this meta-analysis, which is an old one, you can look at the bipolar depression cases, which are type 2 bipolars. These are all patients who had hypomania and before DSM-4 they were labeled as MDD because hypomania was not included in the DSM system until DSM-4 in 1994. So in the studies before that time with antidepressants in MDD, many patients were included who actually had hypomanic episodes who we would now diagnose with type 2 bipolar depression. And what this study shows is very high rates of manic episodes in the tricyclic treated patients and higher with SRIs as well than in the non-bipolar patient. Placebo and SRI were similar, but again, I want to point out that there's much higher rates in the type 2 bipolar patients than in the non-bipolar patients, the unipolar patients, where there's only a fraction of 1% of manic episodes. And these are with 10,000 patients, very large numbers, which show you that indeed, if patients get manic, that means that they either have type 1 or type 2 bipolar depression. It's very, very unlikely that they do not. But it's also true that the SRI switch rate is less than the tricyclic and may not be more than placebo in the type 2 bipolar patients short term. We still have the long-term destabilization rates, though, as we showed you with the rapid cyclers, patients getting worse, and that's the same whether they're type 1 or type 2. And we still have the lack of efficacy, which we showed in our studies was the same in the type 1 and type 2 patients. But what about the other studies that exist on type 2 bipolar depression that report benefit? Many of these studies are done by my colleague Jay Amsterdam in University of Pennsylvania, who's an excellent researcher and a good friend. And I think that his work certainly deserves attention because it does use the typical methods that are accepted these days in studies of psychiatric medications. My issue is with the methods, the relapse prevention design, or so-called enriched design. I think that this method is biased and that it does not give an accurate view of the efficacy of medications, that in fact what it does is it overestimates to such a degree that it's invalid the benefit of the medication being studied. So here's an example. You have fluoxetine, Prozac versus lithium. And in the enriched design, the study pre-selects fluoxetine responders. In other words, before the study begins, patients need to be treated with fluoxetine, as you can see in the top here. If they fail fluoxetine or can't tolerate it, they are not included in the study. They go home. So 148 patients got fluoxetine. Only 81 were included in the study. The other ones didn't do well with it. And then the fluoxetine responders were randomized to stay on it or to switch to other options, in this case, lithium or placebo. What's important about this is it's pre-selected for just the one drug, not for all of them. So it's really not a fair comparison of fluoxetine and lithium. And furthermore, as you know, about a quarter of the sample that initially had gotten the fluoxetine had manic symptoms that led to their discontinuation. So those patients were excluded from the study. 24% had manic episode symptoms with fluoxetine. But once they're excluded, you can see that fluoxetine did better than lithium or placebo. And on the right-hand side, you have manic symptoms. You can see even though there was more with fluoxetine than lithium, when you look at it in absolute numbers, the sample size was small enough that it wasn't statistically significant. And so the researchers concluded that fluoxetine did not have an increased risk of causing mania compared to lithium or placebo. But keep in mind, that's after excluding 24% of patients who actually did get manic on fluoxetine. So again, I don't think this is a valid assessment of the safety of the drug, that's for sure, and efficacy as well, because these are pre-selected to be fluoxetine responders. And so it's not surprising they stay well on it, as opposed to switching them to lithium or coming off it completely and getting placebo. My favorite analogy on this issue is the question of whether you like chocolate cake or vanilla cake. If you like chocolate cake, and then I put you in a study of chocolate versus vanilla cake, you're still going to like chocolate cake. That hasn't proven that chocolate cake is better than vanilla cake. I've pre-selected you to respond to what I'm studying, and that's an invalid design in my view. Now, I will admit, and you need to know, that from the Food and Drug Administration perspective, the FDA, they accept this design. They give indications for drugs based on this design. The NIMH research mainstream accepts the design. But I think that for the reasons I gave you, it is invalid, and that's my critique of the claim that these studies show that these drugs are effective in type 2 bipolar depression. Again, we looked at it in our studies, type 2 versus type 1. In the first study I showed you, there were no benefits. This has been published now. There was no difference between type 1 and type 2 in terms of improvement with depression. In fact, we had a little less depression in the type 1 than type 2 patients. But it's not statistically meaningful, and this is not pre-selected. And when you don't pre-select and you have a more valid comparison, there's no inherent difference between type 1 and type 2 bipolar depression. The drugs seem to be ineffective in both cases. Now, what are we to make of this general issue of the so-called antidepressants being ineffective in bipolar depression? If I've convinced you up to this point that when you look at this scientific research as carefully as you can, the best studies as we can, you don't really find evidence of benefit. If anything, there's harm. If I've convinced you of this point, then let's ask the question why that might be the case. Now, I've said so-called antidepressant a few times because I don't think the word is a good word. The word implies that these drugs work for all kinds of depressive states. And as we've shown, they don't work in bipolar depression, certainly. And so it's not a good word to use. I've suggested a different word that's more clinically neutral, like a monoamine agonist, because all these drugs do is increase norepinephrine, serotonin. The mono means whether they work for this or that kind of depression, I think is a clinical question. You can't assume it with the name of the drug. In fact, they may work better for anxiety symptoms than depression. But besides thinking more clearly about a better word than antidepressants, a more scientifically meaningful word, we might also ask the question where the word depression is meaningful here, or bipolar depression. What do we mean by depression? And what's important to think about is that depression, the way that DSM-4 or 5 define it, so-called major depressive episode, includes a lot of manic symptoms in a lot of people. And that's because even the definition of hypomania requires a 4-day cutoff. That means that if patients have manic symptoms and they last less than 4 days, they last 3 days, 2 days, 1 day, DSM-4 and 5 does not allow you to diagnose it as bipolar illness. You still have to call it major depressive disorder. In the context of an episode, a depressive episode with manic symptoms for 3 days or 2 days is still just called a major depressive episode. It's not called a mixed episode, which is the phrase I would use. Now, DSM-5 has allowed this concept of major depressive disorder with mixed features, but it's not exactly the same as what we're talking about here. Here in the study by Fry, you can see that on the y-axis on the left, you have the Young Mania Rating Scale score. That's a manic scale. Scores of 1, 2, 3, and 4 are very low scores. When people are manic, their scores are often around 20. So these are patients who have depression, but if they have even a little bit of mania, a score of 4 versus 2, they're more likely to get manic with antidepressants. And some of us have called these states of depression with a little bit of manic symptoms mixed depression or the depressive mixed state. But DSM just uses the phrase major depressive episode. Now, this is a larger topic, but I'll just be blunt about it here. I can't give you all my reasons right now, but I've written a lot about this, and perhaps it could be a topic for a later lecture. But the cutoff of DSM of 4 days for hypomania and 1 day for mania is based on zero scientific evidence. It was completely made up to begin with DSM-4 in 1994. It's been rubber stamped by DSM-5 in 2013 with zero scientific evidence to support it. It's just based on the complacent, conservative, cautious belief systems of the mainstream of the psychiatric profession. If you go by the scientific research, studies like this indicate that manic symptoms that last even a few days or that are very mild actually are quite important, both in terms of treatment effects and, if we were to talk about it more, regarding other indicators of validity, such as in this study, the BRIDGE study. Here's a study of over 5,000 patients with clinical depression. And they tested the DSM criteria of 4 days or more for manic symptoms by examining what they call the bipolarity specifier. This is a way of saying, forget about the duration. Let's say it's 3 days. Let's say it's 2 days. Let's say it's 1 day. It doesn't matter. As long as patients have multiple manic symptoms that would otherwise meet manic or hypomanic episode definitions in DSM, and they're in a current depression, we're going to call that a mixed state. And using that definition of a bipolarity specifier, you'll notice that 84% of this population did not meet DSM criteria for bipolar. They didn't have manic symptoms longer than 4 days. And that's typical when you take an unselected sample of patients with depression. About 80% have so-called MDD, about 20% have bipolar definitions. But when you take the majority of the patients being non-bipolar by DSM terms, still what you find is that almost half of them, 47%, have multiple manic symptoms lasting less than 4 days. In other words, their depressive episodes are associated with multiple manic symptoms, racing thoughts, impulsivity, periods of high energy, etc. And these people who have multiple manic symptoms, even though they're brief, had almost a 10-fold increased risk of getting manic on antidepressants, and they had almost a 4-fold increased frequency of bipolar illness in their families. In other words, genetics and treatment effects validate the view that these multiple manic symptoms lasting just less than 4 days are diagnostically meaningful. In diagnostic research, we talk about diagnostic validators, meaning evidence that indicates that symptom differences reflect different diagnoses. So you might have cough with a pneumonia, you might have pneumonia without a cough. The fact that your cough is present as a symptom doesn't mean it's a different diagnosis. In pulmonology, what you do is you look at the pathology of the lung. Well, we can't do that in psychiatry, look at the pathology of the brain yet. So what we do is we look at other lines of evidence that indicate that symptom differences reflect different diagnoses. And the other lines of evidence besides symptoms are genetics, meaning family history, course of the illness, treatment effects, and biological markers if you have it. So here we're looking at two of those validators, treatment effects and genetics. And they both support that the presence of manic symptoms of any duration does indicate a different diagnosis than straightforward so-called depression or so-called MDD. In other words, where I'm trying to go with this is that half of the patients, let's say, who are diagnosed with so-called bipolar depression are actually not depressed at all. They're mixed. They have multiple manic symptoms. And antidepressants aren't effective in those patients, perhaps for that reason, because they're mixed. Let me give you another definition of mixed states. This comes from Koukopoulos from Italy. Koukopoulos was a Greek psychiatrist who worked for many years in Rome and a mentor of mine. And for 50 years, he's been practiced this way, and he taught that when people have depression with these kinds of symptoms, they're very labile, they're very angry, they're very agitated, and then they may have some other classic manic symptoms like rapid racing thoughts, increased libido, sexual impulsivity, etc. When patients have these kinds of symptoms, they have a very angry, labile, psychomotor, excited depression. That's a mixed state. And that's his definition. It's a little different than the previous slide, this bridge study by Angst and colleagues, which uses DSM manic symptoms. Koukopoulos' approach is more of an angry, rageful mania. Let me just pause here and just make a point. In the classic psychopathology literature, going back at least 200 years, depression has always been seen as a slowing down of your thinking, movement, feeling, and behavior. A slowing down. It's not about being sad. Mood is actually not central to so-called mood disorders. It's the psychomotor changes being slowed down in your thinking and movements and your feelings. So you're not motivated, your energy is low, etc. Mania always meant being sped up in your thinking, movement, feeling, and behavior. It's not about being happy. Euphoric mood is uncommon, actually, in mania. Usually patients are irritable or dysphoric or even straightforwardly sad and depressed. Again, mood is not central to so-called mood disorders. What is central is the psychomotor changes. You're sped up in your thinking, movement, and feeling. So what Koukopoulos is describing here is a mixed state, is when you have depression, you're slowed down and you might be sad, but you also have some psychomotor excitation. You're agitated, you're angry, you're labile. depression with psychomotor agitation, excitation. In American psychiatry, people often use the phrase agitated depression, but they pretend that it doesn't really mean anything. It's not especially important. It's just a kind of depression. Koukopoulos' point is that agitation inherently means that you're manic. It's not depression if you're agitated. You might have another condition, maybe schizophrenia, but you're certainly not depressed, because when you're depressed, you're not excited and agitated. You're slowed down and psychomotor retarded, which is the classic concept of melancholia. The DSM does not look at it this way, I understand, but like I said, this is another example where DSM criteria exist, but they're not necessarily scientifically proven. There's scientific evidence to the reverse, and in fact, that's always been the way that most of psychiatry has thought about this before American psychiatry's DSM-3 perspective in 1980, which is what we tend to use now. Let me finish up on a little bit of research using Koukopoulos' criteria that we've done, along with his colleagues in Rome. So in the International Mood Network, which we created as a collaboration of different researchers around the world, we validated Koukopoulos' concept of mixed depression. And we did this in a sample of patients which came from different countries, many different sites. So we took 435 patients. About half of them, well, 3/4 of them met DSM bipolar criteria, about a quarter did not. They met MDD criteria. And about half of them met Koukopoulos' mixed depression criteria. So similar to the Angst study, in this case, more bipolar than non-bipolar patients, but the general finding is that when patients have depression, in the case of bipolar illness, about half the time it's mixed depression, as opposed to what you might call pure depression or melancholia. They're not just depressed, they're not just slowed down, they're actually depressed and excited or agitated and labile and angry. And these mixed depression patients had somewhat more depressive episodes, somewhat more trauma. Those were some features we found. They actually were hospitalized less. And let me just say one more thing about it. In another analysis, which I'm not showing you here, we found that the mixed depression patients, if they got antidepressants, were about 2 times more likely to make suicide attempts than if they did not get antidepressants. And in the other analysis that we did, we also found very little benefit with these patients with antidepressants. Now, another way of looking at whether mixed depression is a reason why antidepressants don't work well in bipolar illness is to look at other studies which may not have defined mixed states the way we are, but which may be analogous in the way that they've looked at it. And one factor that's relevant is anxiety. When patients are mixed, when they have severe agitation, excitation, and mood lability, they do tend to be very anxious. Now, anxiety, in my view, is the fever of psychiatry. It's not itself a diagnosis, just like fever is not a diagnosis in medicine. But it's very common, just like fever is very common, and it's caused by many different things, just as can happen with fever. So just because someone's anxious doesn't mean they have a quote-unquote anxiety disorder, in my view. It's another example of the DSM system's misleading effects, but rather they can have anxiety due to mania, depression, and again, in the mixed states, both mania and depression cause a lot of anxiety. So in this analysis of a range of randomized trials of serotonin reuptake inhibitors for so-called MDD, the researchers found that when you divide the MDD sample up into those with severe anxiety versus not, the more severe the anxiety, the less effective the antidepressants were. So number needed to treat of 22 means very low benefit, whereas a number needed to treat of less than 10 shows good benefit. So it's interesting because serotonin reuptake inhibitors have a direct anti-anxiety effect symptomatically at low doses, but they are very ineffective when there's a lot of anxiety with depression. And it doesn't make any sense if you just think about anxiety and depression the way we traditionally do in the DSM system. But if you think about anxiety being a consequence of mania and the depression really being a mixed state, then it makes sense that the SRIs are less effective. In fact, SRIs can worsen such mixed states. Okay, so I did have these, wanted to show you this study, this analysis also from the Koukopoulos group that we did. This is what I was referring to when I said that there were 2.5 times more suicide attempts in patients who got antidepressants and developed mixed depression, as opposed to if the mixed depression was happening without antidepressants. This is Koukopoulos' own clinic in Rome. And as you can see in his clinic, about half the patients met DSM-MDD criteria, but half patients had mixed depression. Again, it's consistent with the bridge study. You'll notice that we have the word hyperthymic here for temperament. You may not be familiar with that. You're probably familiar with cyclothymia and dysthymia, but you may not, a lot of people don't realize that these affective temperaments traditionally were meant to be mild versions of manic depressive illness. In other words, they're not different than the so-called bipolar or unipolar depression. They're just mild versions of bipolar and unipolar depression happening either in the same person in between their mood episode. They have mild mood symptoms. That's part of their personality, their temperament. Or it happens in their relatives as well. It's biologically and genetically related, so you might have family members with just cyclothymia or hyperthymia. Hyperthymia is not in DSM-3, 4, and 5 for unscientific, unclear reasons, but it means mild manic symptoms as part of your personality. And Koukopoulos and others felt that a lot of patients who have depressive episodes, in between their depressive episodes, they have mild manic symptoms, meaning they're highly charismatic, energetic, workaholics, very productive, very creative. Often they're very successful in their lives. They can be leaders in professions, in politics and such. They're always a little high, but they're a little impulsive too, but not severely, so that they're functional. But then they might have depressive episodes recurrently. And that used to be diagnosed as manic depressive illness, but in the DSM system, hyperthymia is ignored, and the depressive episodes, again, the manic symptoms are ignored, the excitation, agitation is ignored, and it's just labeled a major depressive episode, so they're diagnosed with MDD in the DSM system. But looking at it more carefully, paying attention to the manic symptoms, both for the hyperthymic temperament and for the mixed depressive episodes, looking at it in Koukopoulos' clinic, we found that half the patients have these mixed states. They get more suicidal on antidepressants, which may explain why there's this FDA warning about suicidality with antidepressants, especially in young persons. And in follow-up, in his own practice, Koukopoulos only gave antidepressants to about 3% of his patients. And remember, half of them met MDD criteria. In your DSM system, they'd be considered just MDD. But 97% of them did not need antidepressants. In fact, they got better with mood stabilizers, dopamine blockers, ECT. Their Hamilton Depression Rating Scale scores improved notably. And about half of them never had any episodes in years of follow-up, meaning they were completely cured. So I think it goes to show that there's this other way of thinking about treating so-called depression, both bipolar and unipolar, that pays attention to manic symptoms, that diagnoses mixed states, and then avoids antidepressants in these patients and uses mood stabilizers and dopamine blockers instead, and the patients get better. And here's my last slide. And the point I want to make here is that randomized clinical trials give you an average effect for the average patient. What you see on this slide is the number of faces on the periphery, white, black, young, old. And if you make an average computer simulation of all those faces, you get the face in the middle, which is neither male, female, white, black, young, or old. And that's the effect you get from the various randomized clinical trials. So when we say antidepressants don't work in bipolar depression, what we mean is they don't work for the average patient. Now, you might have a patient or two here and there in whom you might feel there's some benefit, but the average patient reflects the majority of patients. And that means we should not be using these drugs in the majority of people. But we also need to try to figure out what's going on with subgroups. And I wanted to emphasize the mixed depressive subgroup, which I think is a group of patients that does especially poorly with antidepressants and which definitely should not get them. And as I said, that's probably 1/2 of the patients who have depressive episodes, whether they're bipolar or not, even in meaning they have unipolar depression because of the way DSM defines MDD. They're not technically bipolar depressed, but certainly those patients are very common in the bipolar depressed population. But I would emphasize it actually is the case with the so-called MDD population as well, that these mixed states happen in about 1/2 the patients, and the antidepressants do not help them. So I will stop here and summarize and say that I think, let me just pull this back up, I think that antidepressants of bipolar depression are proven ineffective that they should not be used routinely. They should not be used in most people. They definitely should be not used in rapid cycling. They should be stopped in anybody with refractory bipolar illness. And that specifically we should diagnose mixed states more carefully, looking at manic symptoms of any kind for any duration, looking at labile, rageful, angry people, and especially avoiding antidepressants in those patients. And then the dopamine blockers and the so-called mood stabilizers are the more effective treatments in those cases. Thank you for your attention.
All right. Well, thank you, Dr. Ghaemi, for that wonderful presentation. We're going to go ahead and get started with questions now. So the first question is, what is the danger of going manic when you are on strong antidepressants? How do you know when to stop them?
Well, if you start getting manic on antidepressants, you should stop them right away. Any manic symptoms is a reason to stop them, in my opinion.
Great, thank you. Next question. You mentioned that without the antidepressant medication, the depression will go away anyway. However, what if the individual's depression is lasting for a long period and can't seem to get out of it on mood stabilizing meds alone? What do you suggest?
Well, what I meant is the nature of bipolar illness, manic depressive illness, is defined as a recurrent episodic illness. That means it's not chronic. That means you never have symptoms that come and never go away. If that happens, it's not manic depressive illness. It might be schizoaffective illness or schizophrenia, but that's not the nature of manic depression. So from a scientific perspective, the episodes always go away. Of course, if there are some people, a minority, maybe 10%, that have long episodes that last 6 months or longer, and during those episodes they can be quite dysfunctional and there's a high suicidality risk in some people. If that's the case, of course, you do want to treat it. Now, if they're on only about, a general statistic is that only about 1/3 of patients respond to a single mood stabilizer, 2/3 need 2 or more. In other words, say lithium alone will cure 1/3 of people. That's actually quite good. But 2/3 need lithium plus other mood stabilizing agents like lithium plus lamotrigine, lithium plus Depakote, lithium plus Tegretol, or one of the other mood stabilizers plus some of the dopamine blockers like Depakote plus risperidone, lamotrigine plus aripiprazole. There's various combinations. And basically the work of the psychiatrist is to find the combination that works for that patient. But you have to limit yourself to the effective and safe medication classes, which is the mood stabilizers and the dopamine blockers, not the antidepressants. That's the key. So the answer to the question is you need to keep using the combinations of mood stabilizers and dopamine blockers until the patient's mood episodes get better. But I would like to emphasize it's very, very rare that it's a single long episode that you need to treat. It's much more common that in fact the patients are cycling into and out of episodes and they either are not aware of it or they're not appreciating it. And what you're really trying to do is not treat an episode, all episodes go away. It's to prevent future episodes or to reduce the cycling rate.
Great, thank you. The next question is, I am trying to go off medications altogether after trying all of them and being completely miserable. Are there any cases that have done better without any drugs?
There might be one case in the history of humanity, or 5 or 10, but very few. The nature of this disease is that it's recurrent and episodic, as I said, which means it almost always comes back. Probably the reason you haven't gotten better is because you have tried all the medications. I imagine you've probably tried a lot of the antidepressants and amphetamines. If so, that's why you didn't improve. The key is to try fewer medications, the right ones, not all of them.
Okay, great. Thank you. The next question is, what are your thoughts on the new medications for bipolar depression?
Well, I'm not sure which ones they mean, but if then the newest indications that have occurred for some of the dopamine blockers like lorazepam, Latuda, and also I guess some of the other ones are more indicated for major depressive disorder like brexpiprazole, Rexulti. But I think they work, and I think they're helpful as long as people don't use the so-called antidepressants along with them.
Okay, great. Thank you. And the last question we have, is there any data on the cessation of female monthly periods caused by antidepressant medications? And if so, are there long-term consequences of this?
I'm not sure if the question means really that the antidepressant causes cessation of the periods. There's certainly a lot of research on depression or depressive illness being associated with menstrual irregularity, including amenorrhea, complete cessation of periods. Certainly can happen with depression, with anxiety, with stress, PTSD, all kinds of stressful scenarios. And what's cause and what's effect sometimes is debated, but it's very more likely that the menstrual period is affected by the mood and anxiety conditions, and then it becomes irregular or it stops altogether. I didn't know of a lot of literature indicating that the so-called antidepressants, the serotonin reuptacators and such, cause amenorrhea. I'm sure there are some cases, but there's not a strong and common association to that effect to my knowledge. There certainly haven't been any randomized trials that I know of that prove that there's a causal relationship. So I'd have to say that even though it's possible as an uncommon side effect, as many things are, I don't think it's common as an issue with antidepressants, but it's much more common as the effect of having a mood illness. And what may be the case in bipolar illness, again, is if the so-called antidepressants are used and the patient's bipolar illness is worsened, so they have more and more mood episodes, including depression, then you will very frequently have more menstrual irregularity or even amenorrhea as well. So in that case, it's more of a secondary effect of the antidepressant, not as a side effect, but via worsening the mood illness itself.
Great. Thank you for that answer. So that looks like that's it for the questions. So I'm going to go ahead and thank you, Dr. Ghaemi, for sharing your expertise with us today. We hope to see all of you at our next webinar. Thank you.
Thank you.